Catholic moral teaching, especially in the document, the Declaration on Euthanasia, Jurum et Bona, speaks very explicitly regarding what our responsibilities are at the end of life. And so Dr. Behaney from the Catholic Medical Association, the executive director, is going to give us some perspective as to the ramifications of the Obamacare in the care that we give to our elderly and our infirmed. So I'd like to bring up Dr. Behaney.
No, we actually have a code.
Oh, good.
And it's going to work. So, okay. Well, it's wonderful to be here on a Saturday morning and see so many interested people showing up. I'm standing in for Bobby Schindler, who couldn't be here. He has a lot more hair than me, and he also has more hands-on experience with some of the things that are going on out there with patients and families and so on. So I'm going to approach this a slightly different way. I've studied Obamacare a lot, more in general and more in its impact on physicians, but I am going to try to address how it might apply again to the elderly and to the infirm. Now, I wish there was a simple answer to this question. You know, what is this effect going to be? There is no HHS mandate for the infirm and the disabled in Obamacare. And there's no mandate either for the elderly, for example, that they will always get the most basic kinds of care and treatment. So we don't have that kind of guarantee. And in fact, there's very little in the law itself that actually has to do with the treatment of patients. There's a lot about payment for medical services. There's a lot about the government's power, as I'll show you in a second, to regulate care, but there's very little actually about treatment standards. So how am I going to break out this topic? First, I do want to talk a little bit about the nature of Obamacare, because the next thing I will talk about are some specific initiatives and programs and proposals, but I think it helps to keep those things in the context of the larger whole. And finally, I do want to save some room for question and answer. So I'm sure everybody in this audience has probably encountered the healthcare financing and delivery system in our country at some point in time. You know, whether it's a mother going in to have a baby, taking a child into the emergency room to get stitched back up, you know, some sort of unexpected crisis, you name it. I think we've all encountered the system. Maybe we're changing jobs or changing insurance companies, you know, and we're wondering just what that's going to do to our share of the payment or our choice of doctor, you name it. I think we've all encountered it, and what we found is it can be very confusing, very fragmented, very expensive at times. You know, we have had problems in healthcare financing and delivery in this country for many, many years. And people have said, and the U.S. bishops have said, we need healthcare reform. And so finally, in a combination of 2006 and 2008, when we now have a Democratic president and a completely Democratic Congress, someone in government had the power and the ability to say, we're going to fix what's broken. So what is the fix? You know, we have a real problem, as you can see up there. And the fix is, it's a bunch of things. It is to mandate that people buy health insurance and to regulate all employer-provided healthcare insurance. It is to oversee the cost of health insurance and also what any cost increases may or may not be. It is to control what services are actually provided and what healthcare professionals or institutions are paid for those services. It is to control and define quality of care issues. Sometimes, again, that gets into some things are judged not high quality enough to be provided. And finally, the answer involves creating a bureaucracy to monitor and enforce all elements of this control, everything from payment to reporting paperwork. So we have a problem, and we have a theory, and if we can get all this done, the theory is our problems are going to be over. Now, what does this look like when you diagram it? That's what it looks like, and how many people have seen this slide before? I'm just curious. I see a couple hands going up. I don't see many. A staffer, I believe, in Senator Coburn's office completed this diagram simply by reading through the law, tracing references to the Secretary of Health and Human Services. You can see that big red circle in the center. It's the biggest thing you can see there. That is the Secretary of Health and Human Services. In a 1,000-odd page bill, there are 2,500 references to the Secretary of Health and Human Services. And 700 times of those, it says the Secretary shall, and a few hundred times it says the Secretary may. But there's a lot of discretion given to the Secretary of Health and Human Services. So you look at that diagram, and what does it tell us about Obamacare by its very nature? First, it's very large and complex. It's very, very large and complex, and it's going to be very, very expensive. One of my concerns is, to fund all that, I'm going to get to a couple more characteristics, it's going to take spending a lot of money on bureaucracy. Not on healthcare, on bureaucracy. So that's a problem. It's very large and complex. Second, it's very centralized and controlling. Again, what's the big red dot in the center? It's the Secretary of Health and Human Services, who is in a federal agency, right? And the federal government is going to be regulating, defining, approving everything that's done. And the problem with getting a centralized bureaucracy to approve and regulate and define is it takes a lot of time to get it done. You got to work your way through the channels, and it's going to slow down a lot of innovation and so on. Finally, Obamacare is unpredictable and undefined. The bad news, you might say that diagram doesn't look very good. The bad news is it actually, he said he couldn't get everything on one page. It would take a couple more sheets to actually get everything in. So that's not even the whole thing. There are at least 140 new offices, bureaucracies, programs, you name it, that are called for by Obamacare. But the General Accountability Office said there's no way to determine the upper limit. We know it calls for 140-ish new government departments, you name it, but we can't tell you how many more are going to be created. It all has to be determined later. So it's very unpredictable and undefined. So I think we've all heard the news that the employer mandate has been delayed for a year. Why is that? They couldn't give the employers the information they needed, the rules, the costs, the law, to follow the law. They couldn't do it in time. And that's unpredictable. And when things are large and centralized and unpredictable, that's not good for doing the real work that we need to do. It's not good for caring for people. And we know this has had a tremendous effect on employment. There are 4 times the number of part-time jobs being created right now. So much for Obamacare. Let me talk about a couple of specific programs and initiatives. First of all, the Medicare cuts and the effects. And I do think this is one place where we could see potentially very negative effects on the elderly and the severely infirmed. Obamacare actually calls for cuts to Medicare from 2010 to 2019 of over $700 billion. Over $700 billion. The figure originally given by the Congressional Budget Office was $585 billion. But it actually has gone up. Many disability services that are provided through in federal programs are funded out of Medicare. So it will come out. Now, the government says, and nobody is really disputing that $700 billion figure. They say, well, we're not cutting services or programs. We're just cutting reimbursements to people. We're just cutting what we pay hospitals and doctors and some health insurance programs. Well, when you cut that money, people are going to quit participating and quit providing. I don't know if you know this about Medicaid. If you're on Medicaid, your chances of dying, your chances of ill health are actually worse than if you have no health care insurance at all. Many doctors don't take Medicaid, in some states in particular, but it's hard to get to see a doctor when you're on Medicaid. Under Obamacare, they're proposing to reduce Medicare reimbursements to physicians under the Medicaid rate. Now, the bad news is, there's not a lot of good news in that. I mean, the bad news is if they carry that out, doctors will stop seeing those patients. They literally won't be able to afford to do it. They could say, well, guess what? We're not going to cut the money. We're just going to keep paying them. Well, then we're going to go broke faster because we're already going broke. So anyway, Medicare cuts, I think, are potentially highly problematic. I used to be a proud member of the baby boom generation. The older I get, the less of a good deal it seems to be. But baby boomers are retiring at the rate of 10,000 a day and going on Medicare at a rate of 10,000 a day. So Medicare utilization is going to go up 30% in the next 10 years, and they're proposing to cut it by $700 billion. A couple of things here. I think you might have heard these terms: comparative effectiveness research and the Independent Payment Advisory Board. Comparative effectiveness research is a program that purports to find out what are the most effective treatments for diseases, and even the most cost-effective treatments for diseases, with a view to saying, well, if something is not effective or not cost-effective, we shouldn't do it. The money to pay for the initial Comparative Effectiveness Board wasn't given in Obamacare. It was given in the stimulus program of 2009, the $800 billion stimulus program, provided, I don't know, it was like $5 to $10 billion to get the Comparative Effectiveness Research Program going. They've changed the name a bit. They claim that this program will not deny treatments, will not change people's health insurance coverage, but it's going to be very, very influential when a federal agency says these treatments are cost effective and these treatments are not. But anyway, that funding is in there. There is now a patient-centered outcomes research institute, which was funded as part of Obamacare, and that is up and running and will be providing advice to the Secretary of Health and Human Services. The Independent Payment Advisory Board has not been named yet. It's a 15-member board that the president appoints. Their authority is they will be able to say, especially for federal health care spending, it cannot increase above a certain amount each year. Per capita, it cannot increase. And if it does increase, that board has the power to say, this is how we're reducing reimbursements to keep spending at an acceptable level. How will that happen? The way that we sometimes see the government do a 10% across the board, you name it, we'll see. But they have the power. Congress can only override the recommendations of this 15-member panel if 2/3 of the House and 2/3 of the Senate vote to override those recommendations and the president signs it. So how many votes in the House and Senate are at a 66 2/3 to 33 1/3 margin? Not many. So this 15-member panel is going to have a lot of power. Death panels. I think a lot of you heard the term death panels. Sarah Palin made it famous. I bring it up to hopefully provide just a little bit of background. There were two bills for Obamacare, a bill in the House, bill in the Senate. In the House bill, there was a section introduced by an Oregon Congressman, Earl Blumenauer, that called for consultations, advanced care planning consultations when someone got to be age 65. Wasn't clear whether it was mandatory that you have this consultation, or simply that it would be offered as a matter of course, to talk about end-of-life treatment options, to make out a living will, durable power of attorney, and so on. So it said there will be this benefit, there will be payment for the people doing it, it will be a funded benefit, and you must discuss a whole series of topics, what life-sustaining treatments, food and water, this and that. So, but the House bill didn't make it through, and Sarah Palin actually called that a death panel. Now, it certainly brought a lot of attention to it. I'm not sure it was an accurate term, but I was asked to comment about that way back, and when we looked at it, our concerns were that it wasn't clear whether it was mandatory or not, number one. Number two, while you could say someone ought to have that discussion at age 65, the fact that it was called for, that might be years in advance of when somebody actually needed to do it. And yet you're forcing them, or at least highly encouraging them, to make some decisions early on. But it wasn't necessarily appropriate at that time. And finally, it gave the Secretary of Health and Human Services the power to designate, well, a physician could do it, or another healthcare professional as designated by the Secretary of Health and Human Services. So it didn't have to be a physician, and it could be a class of people that the Secretary determined. Now, why is that worrying coming out of Oregon? Well, Oregon has assisted suicide, and there's an organization out there called Compassion and Choices, a pro-death organization that actually counsels and helps people to commit suicide. And what if an organization like that had its representatives approved by the Secretary of Health and Human Services as counselors? And now they've got a revenue stream. Well, this provision did not make it into Obamacare because the House bill didn't make it, only the Senate bill did. But the end of 2010, Obamacare passed in March 2010. At the end of 2010, they tried to slip it in to the law as a rule issued by Health and Human Services. Now, that hit the papers in December of 2010, and there was an immediate outcry, and they pulled back. But would they still like to get that in, and could that be highly problematic? Yes, I think it could. And finally, control of physicians. I think everyone wants a physician who has a conscience. There are many people in our government who are fighting to actually drive those physicians out of the field and prevent people like that from coming in. But people want physicians who are committed to their life and health and well-being. There are a number of things in Obamacare, though, that act to control physicians. And I'm just going to give you one example, and it's a little hard to read this from where I am across the thing, but let me tell you, this is an actual provision of Obamacare, and you could look it up. But essentially what this provision says is, if a doctor wants to prescribe or order durable medical equipment for a patient or home health services, so these are very much things, used by the injured, the disabled, and the elderly, he or she must be a participating physician in Medicare. So here's what's happened over the years. A lot of doctors refuse to take Medicaid patients. The reimbursement's too low. They lose money every time a patient comes in the door. And with these planned cuts in Medicare, there are a lot of physicians who are really tempted to say, I'm going to get out of Medicare and just take cash payments. A lot of doctors are going that route. What this says is, if a doctor wants to order any of these things, that doctor has to be a Medicare participating physician, which means, once you're in the program, then you take the payments, you take the rules, you take all of that stuff. And then the highlighted section, the biggest highlighted section, goes on to say that the Secretary of Health and Human Services can also add to the list of things, durable medical equipment and home health, Part B drugs. So there's a drug benefit under Medicare called Part D, the prescription drug benefit, can add that or any other service, device, treatment, drug. To be able to prescribe those things, you must be in Medicare. So there is a real effort to make physicians become part of the government system, stay in the government system, and once they are, to follow all the rules. And I do think that is concerning. So I'm about to conclude here and then just take any questions and answers on these things. But this is a quote from the Dean of Harvard Medical School in November of 2009. And he said this after the House bill passed and before the Senate bill passed. And this is going to get back to the nature of Obamacare. And what should we think about the elderly and infirm what are we going to see? In discussions with dozens of healthcare leaders and economists, I find near unanimity of opinion that whatever its shape, the final legislation that will emerge from Congress will markedly accelerate national healthcare spending rather than restrain it. Likewise, nearly all agree that the legislation would do little or nothing to improve quality or change healthcare's dysfunctional delivery system. Now, Dr. Fleer is Dean of Harvard Medical School. I bet he's not a Republican. I bet he's not a traditionalist Catholic. I bet he's probably liberal, and he's talking with dozens of other leaders. And at the time, they're all agreeing that whatever comes out is going to drive up spending and do nothing to address the real problems we have, and there are real problems. So, by way of concluding thoughts, I do think there is much to be concerned about by the very nature of Obamacare, by some of those specific initiatives I outlined, and by some of the unintended consequences that we're seeing by way of impact on unemployment and so on. Is there some hope? You could make a question, you could make a point, there is some hope. I know some pro-life, very faithful Catholics who will say, the insurance companies aren't our friends either. If the federal government is in charge of all of this, at least we have the ability, either with votes or lawsuits or lobbying, to make a difference. And so I think we might. It's certainly not out of the question. But I do think there is much to be concerned about and much to be determined over the next several years. So thank you very much.
We'll take 3 questions, so remember.
Okay, so there was a question. Are there some groups of people in the country who are exempted from Obamacare? Short answer is yes. I don't think it's Muslims per se, but the Amish, the Christian Scientists, Native Americans are exempted from the individual mandate. There are several mandates in Obamacare: employer, individual, HHS. I'll make a very quick point, though. There are 3 Christian health sharing ministry programs. These are evangelical Protestant programs that got going in the 80s and 90s that aren't health insurance, but allow faithful Christians to pool their funds to help one another meet their needs. They function almost like high deductible insurance, but they're not insurance. Anyway, these 3 programs, if you belong, you are exempt from the individual mandate under Obamacare, and there are people exploring the possibility of letting Catholics join some of these programs in an organized manner. Anybody could join them, actually, but in an organized manner, people are exploring this. Okay, so the question is, as a result of some of these negative design flaws and negative outcomes, some of which we're already seeing, will an alternative system spring up? I couldn't give you all of Fleer's quotes, but he goes on to say that basically he thinks the plan is to create a system that is designed to fail so that in 4 or 5 years, a complete revamping of all healthcare financing and delivery must take place, probably along the lines of a single payer, federal government only thing. I do think that has been the plan. I will say, though, under the law, no alternative can spring up. My hope is that this fails so hard that we must revise it substantially, and when we do, we must bake into that process the freedom to develop insurance products and healthcare delivery systems in which we can have our Catholic faith and our ethical beliefs and principles respected. That will only happen if we substantially change this law, because this law puts the federal government in control of everything. One more question. Well, the question is it a viable option for doctors to opt out of Medicare because that's such a large class of people? It's very hard administratively to opt out of Medicare. It's very burdensome. It takes you a couple years to get out of the system. You can do it, and you can probably survive. Many people have heard of Medicare Advantage. That's something the Obama administration has targeted for elimination. But the reason we have this Medicare Advantage program is that in the 1990s, doctors were dropping Medicare patients. So there are large classes of doctors, percentage-wise, 30 and 40%, who say they will not take new patients and drop the patients they have. It's one reason the federal government has not allowed the current cuts that are called for in federal law to go forward. So it is a tangled thing. I think some doctors could get out. They could. It wouldn't be easy, but the effects on the doctors and on the patients would be very significant. So, thank you.